A couple of tools that you can use to calculate the risk or the probability of the melanoma cells making it to the lymph nodes. And these tools have been validated in clinical trials. One is used in Australia by the Melanoma Institute of Australia, and the other tool is used at Memorial Sloan Kettering. So again, these tools will help you predict the risk of melanoma making it to the sentinel lymph node, your pathology report, and I can walk you through these tools. This is the first tool. It's used by the Memorial Sloan, or it is published by the Memorial Sloan Kettering Cancer Group. We go here, and I'm gonna put the link for this tool in the description or in the chat box. As you can see here, you can enter your age, and let's say 35-year-old with a 3 millimeter depth. You have to look in the pathology report and make sure you choose the depth of melanoma, not the size, the depth, how deep it go into the skin. The Clark level should be in your melanoma pathology report. Let's say Clark level 4. Where was melanoma location? The location of the melanoma, let's say the extremity. And was there ulceration reported in the pathology report? So look into the ulceration. It is gonna say ulceration is present. If it's present, then you click here yes. If there's no ulceration, you would say no. And then calculate. So the probability of a sentinel lymph node, metastasis, meaning the melanoma cells making it to the first lymph node, or we call it the gate or the door lymph node or the sentinel lymph node, is 36%. The other tool is provided by the Melanoma Institute of Australia. And we go here, and I'm gonna again put the link in the chat box. Let's say the age is 50 years old. Tumor thickness, this is zoom, it is 3 or 2.9 millimeter. Melanoma subtype, here they're looking at melanoma subtypes. There are different subtypes of melanoma: superficial spreading, nodular, lentigo malignant melanoma, acral melanoma, and desmoplastic melanoma. Let's say superficial spreading, which is the most common type of melanoma. Let's say mitosis. Look into the pathology report. You're gonna see the word called mitosis. Check that number. Is it 2, 3, 10? Just check the number. We put 3 here. And also the ulceration status. Look into the pathology report. Check the ulceration. Is it present or not present? If it's present, click yes. Lymphovascular invasion. You can get this information also from your pathology report. And let's say there is a lymphovascular invasion. So this is pretty high-risk melanoma. We put some features of a high-risk melanoma. Let's say calculate the risk, 70%. So 70% chance based on the characteristics, based on the age, the depth, the mitosis, the lymphovascular invasion, and the ulceration status. If we have 100 people with these characteristics, from the 100 people, 70, we will find melanoma cells when we do the lymph node biopsy, or what we call it the sentinel lymph node biopsy. So again, you've got 2 risk prediction tools. As I said before, these risk prediction tools only used when you had a new diagnosis of melanoma. When you hear from your dermatologist about the results of the biopsy, you can come in here to this risk tools and start plugging the numbers and find out what's the chance or the probability of you having a sentinel lymph node biopsy positive. It applied only if you had a biopsy or if you had a surgery for the primary melanoma. If you already had the sentinel lymph node biopsy, you don't need to use that tool because you're going to get the results. If you have a recurrence of the melanoma, like you've got the surgery years ago and now you've got a melanoma recurrence, that doesn't apply. So it's only applied for the first time you were diagnosed with a primary melanoma and you heard the results either from your dermatologist, or you went to the surgeon and the surgeon removed it and informed you that you've got a melanoma.